greetings, everyone, and thank you for being here with us tonight. Allow me to introduce myself. I'm Alison Cobrin, serving as the Executive Director of Alzheimer Group. Alzheimer Group is a charitable organization that has been serving the greater Montreal community for over 39 years. AGI offers therapeutic programs to individuals living with dementia and support services to families and professional care partners, focusing on best practices in dementia care while sensitizing the community through education and awareness. Conferences such as this one is made possible through the generous support of the Lassner Learning Center. During the presentation, please type any questions you have in the Q&A, and they will be answered at the end of the lecture of the conference. Today, it is with great honor that we welcome Dr. Howard Chertkow. Dr. Chertkow is a practicing cognitive neurologist at the Baycrest Health Sciences Center, senior scientist and chair in cognitive neurology and innovation at Baycrest Rotman Research Institute, and professor in the Department of Medicine at the University of Toronto. He is also director of Baycrest's New Anne and Alan Bank Center for Clinical Research Trials, as well as the recently opened Kimmel Family Center for Brain Health. Dr. Chertkow is senior author of the Montreal Cognitive Assessment, which has become an international standard for diagnosis of mild cognitive impairment. And since 2014, Dr. Chertkow has been the scientific director for the Canadian Consortium on Neurodegeneration in Aging. Dr. Chertkow is an active researcher in the area of dementia. His major areas of interest include early diagnosis and therapy of cognitive disorders in Alzheimer's disease and frontotemporal dementia using neuromodulation approaches. Dr. Chertkow's lab is now focused on developing transcranial direct current stimulation as ancillary therapy in elderly individuals with neurodegenerative disease. This evening, Dr. Chertkow will be talking about a promising decade, what's coming in diagnosis, prevention, and treatment of Alzheimer's disease. Welcome, Dr. Chertkow, and thank you so much for being with us this evening.
Thank you, Alison, and thank you to members of the AGI. C'est un très grand plaisir d'être ici ce soir comme conférencier pour faire une présentation sur des aspects reliés à la maladie de Alzheimer. What I'm going to do in the next 45 minutes or so is talk about what's new and what's coming in Alzheimer's disease, talking first about therapy, and then talking about progress in diagnosis and progress in prevention. So what I'm going to do now, I'm going to show a bunch of slides. I'm going to share my screen, and afterwards we're going to have questions. So with that, let me press my screen share, and we should now be starting on the slide. So I hope we're seeing the slides because I'm seeing the slides, so I hope you are too. First, I always mention funding support, and that I am involved with a lot of commercial interest, but there was no support for this presentation. So we're going to talk about therapies for Alzheimer's disease. AD is Alzheimer's disease, advances in the early diagnosis of Alzheimer's disease, and new ideas on preventing Alzheimer's disease. So Alzheimer's disease is a complex illness, and this is the very first patient in 1906, the woman diagnosed by Dr. Alzheimer as having this disease. And treatments ever since then have had three different aspects. They've focused on trying to treat the cognitive problems, improve the symptoms of memory loss and other aspects of thinking, treatments to address the behaviors, anger, agitation, the neuropsychiatric symptoms. And what is new is treatments to try and address the neurological aspects and to try to slow or stop the disease itself. So we're not going to talk about the many treatments for the neuropsychiatric symptoms. we're going to very briefly talk about the cognitive symptom drugs and really focus on what is new and what is coming, that is drugs to try and stop Alzheimer's disease itself. This is a timeline of therapy for Alzheimer's disease. It shows the patient I just showed you was in 1906. Nothing really happened for the next 70 years. And then there was this development of drugs to treat the symptomatology. What we use now, the donepezil, rivastigmine, galantamine, these cholinesterase inhibitors, which if you know anyone with Alzheimer's disease, these are the pills that they are taking. And then development of memantine as a totally different drug. This is all in the 1990s. And then there was a period between 2004 and 2022, that's about 18 years, with no new drugs developed. And then now in the past couple of years, we have something new. I'll be talking about the anti-amyloid immunotherapy drugs, the first new drugs since 2004. So this is real progress and things are gearing up. What you're used to if you know about Alzheimer's disease or have a family member with Alzheimer's disease, these are the drugs we've been using for the past 25 years. They're called cholinesterase inhibitors, Aricept, rivastigmine, galantamine, the rivastigmine patch. These provide modest improvement or stabilization. And in about a quarter of people with Alzheimer's disease, they provide really no benefit. The best we hope for is that they will roll back the clock by about 6 to 12 months. Memantine is a very different drug, and it is approved for moderate to severe Alzheimer's disease, has a mild benefit, particularly for people with agitation. In the consensus conference that we have every few years on diagnosis and treatment in Canada, it's been recommended that all of these cholinesterase inhibitors are available in Canada. They all work to some degree. They're all viable treatments. They're not earth-shattering. They don't cure the disease. They don't stop it. They don't return people to normal. There's no evidence that one is any better than the other, and it's hard to decide which one to use, but basically all three can be used, and some people do respond better to one than another. There's also evidence that using the two drugs, memantine and a cholinesterase inhibitor together, you get more bang for your buck than either alone. This is the progression of people on no treatment going from basically declining to the point of nursing home placement. The progression is more slow if they're on cholinesterase inhibitor, but it's even slower if they're on both of the drugs. So why is this not used more? Well, there are hurdles, often government financial hurdles, preventing us from using the combination more frequently, but there is a rational reason to use both. What can we say about cholinesterase inhibitors used earlier in people with mild cognitive impairment, MCI? This is the stage where someone has mild memory loss, but they're not yet called dementia. They're not yet often labeled as Alzheimer's disease. Basically, there's no evidence that this delays the onset of Alzheimer's disease or the onset of dementia, and it's not negligible side effects. So cholinesterase inhibitors do not modify, they don't slow the progression of the disease. We don't use them in MCI or for prevention. So that gets us to the current decade where new therapies are rapidly coming forward. And it's a much more hopeful decade than 10 years or 15 or 20 years ago. There are new drugs to slow or stop or modify Alzheimer's disease. And these are what we call disease-modifying therapies. Now, we're going to see all of these approaches listed here coming out with new medications which are being tested. And all of these are in some stage of being tested right now. I'm going to first focus on these first two, really the idea of removing amyloid. And I want to point out, and I'll come back to this point, that we don't really know the cause of Alzheimer's disease. We don't know if it's the same cause in every patient. So you may read a lot about removing amyloid as the disease-modifying therapy to try to stop Alzheimer's disease. That's because that's what we have. But it is quite possible that some of these other mechanisms replacing growth factors, fixing the vascular function, addressing inflammation or impaired bioenergetics or cell metabolism or neuroprotection. These might be just as effective, and maybe it'll be a combination of approaches, and maybe it has to be personalized therapy. What's good for one patient isn't necessarily going to be good for all of the patients. So let's talk about amyloid, because that's where the field is at right now. We focus on the two things that you see under the microscope when you look at the brain of somebody who has died with Alzheimer's disease. You see senile plaques in the brain tissue, shown here in a cartoon, and these are made up of amyloid. And then you see changes inside the cells. You don't see in normal healthy cells these tangles, which are made up of tau protein, and they're called neurofibrillary tangles. And most of the disease-modifying treatments that are coming out this decade are based on these two approaches, mainly the amyloid ones. What has happened is that we have a way to look at amyloid in the brain, and this is a patient with Alzheimer's disease who's been given a PET scan with an amyloid tracer. This means a chemical that is injected in the blood, goes to the brain and binds to the amyloid in the brain. And this person with Alzheimer's disease has a lot of amyloid showing up as the yellow and red colors. And what has been found is that if you use these anti-amyloid immunotherapy drugs, in this case, one called aducanumab, but there are about 3 others that are coming to the forefront. This is the baseline scan, and then we're going to see scans 1 year later. In a patient who's been treated with a placebo over the course of that year, there's really no change. You see the red and yellow amyloid, and it's still there a year later. Maybe there's even a bit more. And compare that to someone on the higher dose of aducanumab. Here's the brain at baseline. Here it is a year later. The amyloid has largely been removed from the brain. And it is clear that these anti-amyloid drugs remove amyloid. And it's quite dramatic in many cases. You can see it on an individual level if you do the scan a year later. So that's great, but is that actually a cure for Alzheimer's disease? 25 years ago, there were many people who said Alzheimer's is a disease of amyloid. If only we could get rid of the amyloid, we would cure the disease. Well, now we have ways to get rid of the amyloid, but it has not cured the disease. It has slowed the progression. So aducanumab was the one who came out first 2 years ago, and the company did 2 large studies called Emerge and Engage. And basically, what this diagram is showing you is Emerge was effective. 0 means it was no better than placebo. And if you're on the left here, it favors the results, favored the drug over placebo. Emerge had a result that favored the drug, but the other study, Engage, was just the same as placebo. It didn't work. And if you average the two studies together, it crosses this 0 point, which is sort of a fail. So one study succeeded, one study failed in meeting their endpoint comparing to placebo. However, there was a decision made in the United States to release the drug because it was so effective in getting rid of amyloid. In Canada, Health Canada basically said, this isn't good enough, you have to do another study. So they initially tried to get the drug released in Canada, then they withdrew the dossier. So aducanumab, I'll come back to it, is available in United States. If you have a friend who's living in Florida, who has a family member with Alzheimer's disease, they can get intravenous access to aducanumab given by intravenous injection once a month, and it costs about $27,000 a year, plus you have to pay for multiple MRI scans. So all in all, probably it costs about $40,000 a year US to go on aducanumab treatment. Now, that's, in the United States, there are many patients now who are getting this treatment, but it hasn't come to Canada. The next anti-amyloid drug that came out, and this is just last year, is called lecanemab, and it's even better. It targets the protofibrils, and this is showing the biology of amyloid that starts as a single monomer. See the little round circle, and these bind together, and then those bind together to make protofibrils, and then they're deposited into these plaques. So lecanemab basically has a somewhat different mechanism to bind to amyloid, and it binds to these amyloid beta. This is the symbol for amyloid in the brain, and causes it to be eaten out by inflammatory cells and cleared out of the brain. How did it do? Well, it did somewhat better, and this was published basically a year ago in New England Journal of Medicine. This study, which was called Clarity AD, met its goal, which was to show that it was people on the drug did not deteriorate as much as people on placebo. And this is basically, this is a individuals on the drug study, which was quite large, followed over 18 months. So that's a year and a half. The ones on placebo are in the blue line. This basically means they're getting worse. The ones on lecanemab are still getting worse, but not quite as rapidly. And basically, you can see how many subjects were involved in this study. And without going into details, we can say lecanemab cleared out the amyloid and slowed the progression of the disease. It didn't stop it. It also showed the people on the treatment had less decline in their day-to-day function compared to placebo. Again, you can see this curve, the decline is not as steep as people on placebo. So what does that mean in real life? Well, people basically will decline, instead of declining over 4 years, they decline over 5 years. But basically, on the basis of this, the FDA in the United States approved lecanemab under the trade name Leqembi basically 1 year ago. So it is also available in the United States, and they've applied to Health Canada for approval in Canada, and I expect that it will be approved. This comes from the companies Eisai and Biogen, so it would not be surprising to me if Health Canada approves Leqembi in the coming 6 months, because it did show that it slowed the progression. The question is whether that really makes a difference for families and for individuals with Alzheimer's disease. Another drug which is on the way to being released is called donanemab from Lilly, and their results were presented just 6 months ago at this is the big Alzheimer's meeting in Amsterdam. And again, these are the individuals on placebo. These are the individuals on donanemab, and this is tracking their cognitive function. This is tracking their cognitive function. This is tracking their day-to-day functional behavior. And again, the ones on the treatment get worse, but not as quickly as the ones on placebo. So they said in their group, there's a 35% slowing of people on the drug. Again, to interpret this, one way they've suggested is that you look at this idea of time saved, the time to reach this point of being moderately, having a moderate dementia, being more significantly impaired, and the people on the drug reach that point more slowly. And what they said was that it added maybe 5.5 months of decent function over the course of 18 months. But people still got worse. It was not a cure, it did not stabilize the disease. Now, we have to say this is a group result. Maybe, and we haven't seen these results yet, maybe there were some individuals who stabilized and did not get worse, but the company hasn't made that claim. So has this been a paradigm shift? Has this been real progress? Some people say yes. They say before this is anti-amyloid disease modifying therapy. Before these therapies, there was no meaningful way to slow Alzheimer's disease, and now there is meaningful therapy to offer. Before, a patient's family said, well, there's no real hope for the future. People are going to get worse, and maybe now there is more hope. And there's more enthusiasm for people in medical school to get into specialties where they treat dementia patients because there's something meaningful to offer. Before, we used to say Alzheimer's was the only one of the 10 top chronic diseases without any disease-modifying therapy. And now we have a medication that modifies the course. On the other hand, looking at these numbers, that there's 27% slowing or 35% slowing, this is very modest clinical response. This is Ron Peterson's a big expert in the field. He said it didn't stop the disease. It didn't make anyone better. And the drugs are so expensive, they may never make it to Quebec. RAMQ may simply refuse to cover it for such a modest impact. Also, you should know about a quarter of the people treated developed what's called ARIA, amyloid-related imaging abnormalities with small bleeds in the brain or swelling. Now, most of these did not develop symptoms, but some people did. So overall, and this is a picture showing what these ARIA look like. This is someone with swelling in their brain who's on the medication, and someone with a little bit of bleeding inside the brain. So they're not innocuous drugs. The prices are a little crazy. The proposed price in the United States is $26,000 a year for the drugs. Now, the companies say it'll be less in Canada, but potentially at this price, it would add, if everyone who qualified took them, might add $6 billion a year in Canada on the drug bill. Currently, the total drug budget for Canada, province by province, added up is about $30 billion. And the anti-amyloid drugs could add another $6 billion. So people have argued billions of dollars to be devoted to what is really a marginal disease-modifying therapy, and it means it's getting diverted from other treatments and from other research and hiring more nurses. So is it really worth it? My summary is that in baseball terms, lecanemab, aducanumab, donanemab, they're like a single base hit. This is not a home run against Alzheimer's disease, doesn't stop the disease, doesn't cure it, but it is of some benefit more than we had before. So that's what's going to be coming already coming in the States. They will be coming to Canada, I expect, in the next months to years. So maybe we should view this as the first step towards really meaningful treatment to stop Alzheimer's disease. And look, you have to start somewhere. So this is a baby taking a first step. Now, why is it so hard to find drugs to treat Alzheimer's? Why hasn't this anti-amyloid drug been the knockout? That's because maybe Alzheimer's isn't just due to the amyloid accumulation in this box. Maybe there's multiple mechanisms, as I've said. Maybe you need to use multiple medications together. And then there's some interactions we don't understand between what's in the brain and other diseases, people having hypertension, obesity, diabetes, all of those interact with the brain to give someone a dementia with memory loss. So we have to look at the fact that we will need other classes of medications, and those other classes are coming slowly down the pipe. This is a drug, a small study announced the very positive result about 3 months ago. This is blarcamazine, which is sigma-1 agonist. All you need to know is this has nothing to do with amyloid, and it seems to be helping people with Alzheimer's disease, slowed the progression by about 28% after 1 year. So maybe if this was given with an anti-amyloid, maybe you'd get a double benefit. And this totally another different drug, bryostatin. Again, it was a small study, but the important thing is a totally different mechanism. So it may be that we need to have multiple drugs with multiple different mechanisms to stop the disease. And I think that's what we're going to see in the coming decade. Question is, how good will they be together, and what will be the price tag? This decade, we're going to see a host of new disease-modifying therapies making it to successful testing and probably being released. Maybe we'll have to have them in combination, or maybe they'll have to be personalized with different people receiving different drugs based on their brain profile. How many of them will be put on the provincial formulary? This is going to be a question I can't answer. I'm going to turn from treatment to talking about earlier diagnosis. And there have been very important advances in diagnosis gradually over the past 25 years. Now, individuals have said, what does it matter if you get earlier diagnosis unless you have better treatments? And that's why I talked about the treatments first. So what has happened in early diagnosis? Well, we recognize people with dementia, and Alzheimer's disease is the leading cause of dementia. Dementia meaning there's significant loss of memory and other cognitive function. And it's sufficient to impair your day-to-day function. You can't pay the bills. You can't handle your personal affairs or organize your life or work the same way. But before that, there's a stage of mild cognitive impairment for 5 to 10 years where people have very mild memory loss, but they're able to carry on their daily life the same as before without any real loss of function. So no functional loss, that's what we see in mild cognitive impairment. And there's many people with this, as in this category. And before that, there are people who have normal cognitive function, but if you looked in their brains, you might see the beginning of changes that later on, years later, will cause dementia. So the hope is by picking up Alzheimer's disease at this stage, or even at this stage, we'll be able to start therapies earlier on. How can we do that? Well, we can do it by looking at just your risk factors, and there have been scores that have been laid out. This is by the Swedish group under Mia Kivipelto, and basically, if you look at someone's age, education, blood pressure, are they obese? Do they have high blood pressure? You can basically generate a risk of having brain disease like dementia 20 to 40 years later. If you have higher blood pressure and you're obese and you're inactive, you score higher on this score, and your chances of getting dementia 20 years later is much higher. So this is sort of a clinical rating scale. We can test for genetics now in ways we couldn't 10 or 20 years ago. Now, many of you have heard of the ApoE4 gene. This is the leading risk gene. If you have an E4, or worse, if you have 2 copies of an E4, it increases your risk of getting Alzheimer's disease. But now we know about 87 risk genes, not just E4. So by knowing these 87 risk genes, we can stratify and say who is at the highest genetic risk. However, we aren't using this in screening. Screening with ApoE genotype and these other risk genes in people who don't have memory loss, what we call asymptomatic, no symptoms. This isn't recommended because it said not very specific or sensitive. In other words, only half of your risk is genetic. Even if you have bad genes, that does not mean that you're definitely going to get Alzheimer's. If you have good genes, you can still get it if you have other risk factors. So what's the point of testing genetics? We don't test the genetics in the memory clinic. Similarly, when you're trying to diagnose Alzheimer's disease, we don't really do much genetic testing or even look at the ApoE genotype because it can lead to errors. We can say, oh, this person has 2 E4 genes, they must have Alzheimer's. Well, we can be wrong. So the role of genetic testing, it really hasn't yet percolated into your doctor's office, but we can do it in research studies. We're doing this all the time, checking the genes. We can look at the structure of the brain in Alzheimer's disease. In people with Alzheimer's disease, they get brain atrophy. That means shrinkage. Atrophy is shrinkage. Here's a normal brain. For a neurologist, this is the way a brain should look. In Alzheimer's disease, you can see the shrinkage on the surface, the shrinkage with enlargement of the ventricle. This is a fluid-filled cavity. And the shrinkage here, most importantly, in what we call the medial temporal lobe, the part of the brain that has to do with memory. So this shrinkage is evident very early in Alzheimer's, even before someone is called dementia. And we have people with mild cognitive impairment who are already showing brain shrinkage. How do we pick this up? Well, we don't take out the brain, but you can do an MRI scan and get exactly the same image, which I'll show you. So here's MRI images focused on this medial temporal lobe. And here's someone you see there's not much shrinkage here. If you go all the way up here, see this one has a lot more shrinkage. So this shrinkage in the medial temporal, this medial temporal atrophy measure is a risk factor. If someone has mild memory loss and this shrinkage, there's a good chance they're going to go on to Alzheimer's disease. So this is what we call a biomarker. And we can measure these There are ways, companies that will measure the size of the medial temporal lobe and look at the hippocampus, which is the main memory organ there, and tell you how their size compares with other people, their age and sex. So brain imaging are ways to measure the structural change. And we can also measure now the biology, looking for amyloid and tau proteins. Now, looking for amyloid proteins is another way to get a biomarker. And this allows us to look for Alzheimer's disease in people who do not even have memory loss. Looking in the population, we can see the prevalence of Alzheimer's. This means number of people with Alzheimer's goes up and up and up in the 70s and 80s. But if we look in PET scans, we can see the senile plaques full of amyloid going up 15 years earlier. So we can pick up Alzheimer's disease 15 years earlier by doing PET scans on everyone. And this is done with PIB. This study was done with Pittsburgh B compound, which is a PET ligand, a PET chemical that binds to the amyloid. So if we did everyone in the population, we would pick up Alzheimer's disease 15 years earlier. The trouble is these scans cost $5,000 a piece. It would be very expensive. But here's what it looks like. Here's an individual with very mild memory changes, maybe means nothing. And the PET scan, we're looking for the red and yellow areas, and you see almost nothing here. This person has no amyloid in their brain. In contrast, here's another individual with the same amount of very mild memory changes, and the PIB PET scan shows amyloid all through the brain in particular areas where Alzheimer's likes to go. So using the PET scan, we can say this person is going to go on to Alzheimer's dementia over time, even though right now, today, their memory loss is extremely mild. So this is another imaging biomarker. This is a PET scan, very expensive. In the next decade, we're going to be able to do the same thing with blood. There are new blood based, and CSF is cerebrospinal fluid that you get by putting a needle in the back and doing a lumbar puncture. So that's a little scary and invasive, but a blood test is what we need, and the blood tests are coming. They're coming because there's a technology called Simoa, single molecular array, and it is allowing us to measure things in fluid, in blood, things we could never measure before. It's going to be low cost. It's not really what we call invasive. People go for blood tests all the time. It's fairly simple and it won't be that expensive. And it's going to be good for potential widespread clinical use. So early diagnosis by a blood test is going to come within the next decade. Simoa is so important. I've even made a diagram picture to show it, but I'm not going to talk about the technology. So you've heard it tonight, single molecular array. This is a breakthrough in diagnosis. Simoa is so sensitive. If I took a sugar cube and dropped it into a swimming pool and did a Simoa test, the Simoa test would say there's sugar in this swimming pool. So Simoa is able to pick up a little bit of tau protein that gets into the blood from the brain, and a little bit of amyloid that gets into the blood from the brain, and therefore detect the abnormalities of the brain by measuring the blood. Jump over this. So we now have these high precision. Plasma is basically blood that's been where you've gotten the cells out of it. So we can measure this amyloid test, and we can measure the phospho-tau, which is based on the phospho-tau 181 that looks at the other protein, the tau protein, the neurofibrillary tangles. That might be even better. I'm very proud of this because this is a study that was largely based out of Montreal with Dr. Rosa Neto and Gauthier at McGill, and partly funded by our Canadian organization, the CCNA. So this is a Canadian contribution to finding a blood test. So the blood tests are coming. They're going to make a big difference. Last part, for a few minutes, I'm going to talk about the idea of prevention. So it's proving so hard to cure Alzheimer's disease. We think maybe there should be a lot more emphasis put on preventing it. Here's the story of your brain as you get older. There are risk factors for dementia. that are damaging the neurons of brain cells and damaging the blood supply, so-called vascular insults. And those are tending towards dementia. And those are risk factors your entire adult life. And then there are what we call protection or reserve or resilience factors that are protecting your brain. And the earliest of those is education in your, in your teens and 20s. Education helps protect the brain. And I'm going to be talking about resilience factors versus risk factors. So how to conceptualize this? Well, I've been watching a lot of football. So let's think of your brain as the quarterback on a football team. And you've got the brain is under attack. The other team is attacking you. Here's the brain, it's under attack. The attack is the opposing team, and we think of aging of the brain and bad proteins and free radicals in the brain and poor blood flow and inflammation and toxins. They're all attacking your brain. And on the other hand, you've got your own linemen who are protecting the brain, and those are these resilience factors: brain reserve, cognitive reserve, good lifetime habits. So think of it as two opposing things: the attackers and the protectors, and the balance between them will determine whether this individual's brain gets dementia or not. There are genes that you inherit that make you more or less susceptible to these attacking factors. So let's talk about how we understand these two attack and protection factors. Something called the Lancet Commission, been very highly publicized. They looked at all the evidence and they talked about 12 known lifestyle factors that affect your risk of getting dementia and could potentially be modified or controlled. So this is an important list. Things that will tend to increase your risk of getting dementia: low levels of education, and we mean people who never got to high school. The more education you get for every year, it's protecting your brain a little bit. Head injuries. In my memory clinic at the Jewish General in Montreal, I saw people who had been boxers, football players, hockey players. Concussions and head injuries are a risk. Now we recognize that air pollution, people who live within a block of a major highway, it increases their risk. Hearing loss, if people have hearing loss and they don't get hearing aids, it increases their risk. People who are physically inactive and aren't exercising, that increases their risk. Things that are bad for your blood supply: high blood pressure that's not treated. And we used to think that the systolic could be up to 160 safely. Now we think it should be treated if it's over 140. So your family doctor is probably much more stringent in treating high blood pressure than he used to be. Other things bad for your blood supply: diabetes, obesity, smoking, all of those are bad for your heart, cause heart attacks, also cause Alzheimer's dementia. Then there are toxins like alcohol, and that should be avoided. Poor sleep also seems to be a factor. Anyone who gets less than 6 hours of sleep a night, that increases the risk of getting Alzheimer's disease. Finally, we can look at social issues: depression, isolation, loneliness, and lack of meaning in your life. These are social factors that seem to increase your risk. And all of these, the important things, these can all be modified. These are lifestyle things that any individual can change at any age. How do these work? Well, think of the football team. We're trying, by manipulating these lifestyle features, we're trying to reduce the damage, reduce the damage to the brain, or increase the cognitive reserve, the brain protection. And this is how we can modify our lifestyle to prevent dementia. Increasing cognitive reserve, well, there are things that are hard to change overnight. For example, higher socioeconomic status and income and a complex work are all good at preserving, increasing your cognitive reserve. More education, speaking multiple languages, bilingualism, trilingualism are all good for your brain. Other things which may be more amenable to intervention are Getting more exercise, that increases your reserve. It's probably the most effective thing, according to the Cochrane study in England. It's getting more mental stimulation, getting hearing aids, increasing your social contact, and maybe in the future there'll be molecules or drugs that will actually increase your brain reserve to prevent dementia. We don't have those yet. But look at this list. What can you do that would apply to you to increase your cognitive reserve? Exercise is the most robust thing. It's good for your cardiovascular health. It's good for the brain. Everyone should be getting 150 minutes a week of fairly intense aerobic exercise every week. Diet is another area that can be modified. It's been shown that diets that are good for you have antioxidants like orange juice, flavonoids like blueberries, lower your homocysteine level by having green leafy vegetables, B6, B12 vitamins. And there's some diets like the Mediterranean and Mind diet that sort of put all of these together. Instead of memorizing this, let's go on the Baycrest website and look up the Brain Health Food Guide, and you can download a copy of all of the things we recommend in your diet to help prevent dementia and preserve your brain. The other things are cold water fish that gives you omega fatty acids, and a little bit of coffee every day. So there are things in your diet that it's pretty clear help prevent dementia. I mentioned having good sleep. We know that sleep disruption is common and associated with a higher risk of getting dementia. So you've got to get enough sleep. And if you have sleep apnea, you have to get it treated. Unusual things, flossing. And people who floss at least once a day have a lower chance of getting dementia because they're getting rid of bacteria in their gums. And then I mentioned their loneliness and lack of purpose, stress, depression, lack of social interaction, lack of a social network, all increase dementia later on. And interesting, if you're unmarried, if an unmarried man has a much higher rate of getting dementia, Alzheimer's disease, or MCI if you don't have a partner. For women, it's less important, but men, you have to be married. So resources, if I've gone through this list pretty quickly, if you go on YouTube and put in Chertkow dementia prevention, you can find we made these 15 little videos about things you can do to reduce your risk of dementia, and I highly recommend it. So that's my name, dementia prevention. Go on YouTube or go on the Baycrest website. Prevention is so important that in our national organization, CCNA, we've become members of this called Worldwide Fingers. These are groups around the world that are trying to develop prevention strategies. Canada is one of them. We're working with these other countries to figure out better ways to prevent dementia. What we've developed in our national CCNA program is an online education program called Brain Health Pro. And if you go on our CCNA website, you can learn a bit more about this. We're going to be opening this up to the public in the coming year. And it's a way to learn about preventing dementia. And we look at the 7 different risk factor areas and what you can do to help your vision and hearing, your sleep, getting more cognitive activities, social and psychological health, vascular health, physical activity, and nutrition, and what you can be doing to improve your brain health to try and prevent dementia. So it's a wonderful educational program with all these chapters. And if you look by summertime, it should be available to everybody, I think. What about drugs to prevent Alzheimer's disease? Well, all of these drugs, I mentioned this list earlier, to treat Alzheimer's, it's possible that some of them are low enough toxicity that they could be used for neuroprotection to try and prevent Alzheimer's disease. This is in the future. No one has really shown there are drugs to prevent Alzheimer's disease. I think this decade we're going to have the important research to look at that. I suspect that in 20 years, maybe not this decade, we'll have worked out a prevention and treatment cocktail with risk factor interventions such as lowering your blood pressure, anti-amyloid and tau, neuroprotection agents, dietary interventions, maybe a combination, a cocktail will be what people use to prevent dementia. But maybe it'll have to be personalized. Maybe it simply won't be the same for everybody. We're in Baycrest, we're now opening the Kimmel Family Center for Brain Health. This is going to be a center devoted to try and work out programs to help people prevent dementia. There's going to be a whole set of programs that fit in with all these building cognitive reserve things that I talked about earlier on. And we hope we're going to be able to show that by getting people into centers, sort of like the Cummings Center, that we can help reduce their risk of dementia. And so it's going to be deliver programming in tune with the current evidence on dementia prevention, embedded in research and clinical trials. So this is a new initiative of Baycrest that I hope you'll be hearing about. In conclusion, Alzheimer's and dementia are complex diseases, hard to treat with a single molecule. I believe that many new disease-modifying therapies will arrive in the next 10 years. We don't know the cost of them, and we don't know whether they'll get to Canada. We don't know whether they'll get to Quebec. So there are unknowns. A blood test for Alzheimer's disease is certainly coming soon. We know a lot about risk factors and potential prevention strategies. Your risk is probably half genetics and half lifestyle. So prevention of dementia is now possible, but to an unknown degree. Is it just a little bit, or can it be a lot? More trials are needed, and we hope we'll be mounting these trials here in Canada. But I believe there are real lifestyle changes that we can all implement in our lives to lower our risk of dementia. And on that note, this is a picture of my lab in Toronto and still operating in Montreal through the Jewish General. And this is prior to the pandemic. So on that note, I'm going to stop sharing my screen and happy to take questions.
Thank you very much, Dr. Chertkow. That was very enlightening about the different progress that we've been, within Canada that are available for us. And it seemed hopeful for our families as well, especially nowadays. So if you have any question, you can write your questions on the Q&A. But Dr. Chertkow, one of the questions that we have in here is like about the hearing loss that you mentioned. So is it because if you have like problem hearing, so you tend to be socially isolated, or are there any other factors that come into play?
Good question. The answer is we are not sure. We have in our national CCNA, we actually have a team on looking at hearing loss and dementia, and this is actually directed by Dr. Natalie Phillips at Concordia and Dr. Walter Wittich at University of Montreal. And they're looking at, is it that people who have poor hearing become socially isolated, or is it actually physically hearing loss? You're not stimulating the brain as much, and that causes the dementia to progress more rapidly, or is it a combination? So what we do know is that anyone who needs hearing aids should get hearing aids because it's good to not only to improve your hearing, but it is a way to reduce what is clearly a real risk factor for dementia. Why it is, further research is needed to elucidate the exact mechanism.
Okay. Another question in here about the new drugs that you have mentioned, the aducanumab and the rest. There's been report of, like, as you mentioned, some of the side effects, the bleed and everything. So what is your opinion on this? Like, should we, as for our families that wants to try this drugs, so what is your opinion and what is your recommendation?
The community, the medical community, is struggling with how to handle these drugs when they come to Canada, if they come to Canada. In the United States, the recommendations are that the medications should be given at centers that have an emergency, have that they're sort of saying not in the family doctor's office, because there has to be an infusion, sort of like a chemotherapy center where you have infusions and you have to watch that people don't have reactions. We have to get MRI scans done before starting, because if you have any evidence of bleeding in the brain, you shouldn't go on these drugs. And then you should get MRI scans done 3 or 4 times during the first year, just to make sure that nothing is going wrong. And if you do it this way, it's a minority of patients who develop the swelling and the microbleeds. Most of them didn't have symptoms, but this was within a very controlled clinical trial setting where people were being checked every month. So what will happen in Canada or in the real world, where it's much harder to get an MRI scan and the doctor doesn't check you every month, will we see a lot more people who have these side effects? We simply don't know. So I believe that when they come to Canada, if the price is lowered and if they're accepted onto a provincial formulary, that we will, the neurologists, the geriatricians, the specialists will figure out how to give them, but it's not going to be in every doctor's office. Then you get the problem. What if it's just in big teaching centers like McGill University, University of Montreal? What about people who live in rural settings, who live in the country? They may not get access to them just because of geography. So it's like a geographic lottery, and that's not really fair either. So there's some serious issues that we're going to have to confront, as physicians and as a society, and working with the government about how to bring these drugs in. And again, we don't know if there are some patients who get a lot of benefit and some patients who get no benefit. We don't know how long to use the drug. So there are many question marks, many questions that remain that I would like to see answered before we bring in these drugs to use them.
So I have another question, Dr. Chertkow. This is in regards to early onset Alzheimer's. So what can you tell us about early onset Alzheimer's? Someone in their early 60s diagnosed, is the progression similar, faster, worse than someone who is diagnosed in their late 70s or 80s?
Alzheimer's disease is very, very heterogeneous, which means it's very variable. We see people, many people who get it when they become frail in their 80s and 90s, and yet there are other people who get it in their 60s when they're robust. There's some people who get it and it goes very slowly, and others who get it and it goes very fast. And some people get it, it's just their memory, and others get it and become very agitated and aggressive to their family. So we struggle to understand why there's such variety and what explains these differences. People who get it earlier on, and about 15% of our patients get Alzheimer's disease before age 60, they tend to have a more rapid course, a more aggressive course, and it's almost like sometimes seems like a different disease from people in their 80s. There are people who get it very early on in their 40s and 50s for reasons of getting a very bad gene that is inherited. And this is called familial Alzheimer's disease. Not common, it's probably less than 5% of our patients. But the other 15% who get it at an early age, sometimes we can think of a reason why. For example, I had a patient who was played professional sports, professional football, and got head injuries every week. But then you have other patients where you simply don't have an explanation for why it came on so early and proceeded so rapidly.
Okay, thank you, doctor. Another question in here, how do you think the finding that gut microbiomes can indicate preclinical AD will affect detection, prevention, and treatment options in the future?
Good. So what is the microbiome? Well, when you step on the scales and weigh yourself in the morning, 3 pounds of that is not you. 3 pounds of that weight is bacteria, and the bacteria in your mouth and going into your stomach and in your intestine. Surface is covered by bacteria. So 3 pounds of you is actually bacteria. And the bacteria have been living inside us ever, for hundreds of thousands of years. And they do some good things. They help with digestion, and they help metabolizing things, they help making vitamins. So we can't really live without the bacteria. But it's been shown that people with Parkinson's disease and people with Alzheimer's disease, in some cases, the bacteria, and this is called the microbiome, the bacteria are different. And we can measure the microbiome, we can measure the DNA in a stool sample or in your mouth or in your saliva. And why is it different? And what does that mean? If it's your mouth, maybe is it that people with Alzheimer's disease aren't flossing and brushing as much? Or, and this seems to be more likely, there are some forms of bacteria that release toxins that affect the brain. And this is why flossing every day actually lowers your risk of getting Alzheimer's disease. So the microbiome seems to be doing something. And more, and this has just exploded in the past 10 years. We're learning all these different illnesses where the microbiome is playing a role. And these go from illnesses of the gut, like ulcerative colitis, to things like asthma. And the thing is, if the microbiome change is causing the disease, it's a way to treat it as well. So you can take in good bacteria to counter the bad bacteria. So we're starting to look in our national study. We looked at the microbiome in different forms of dementia. We're just analyzing those results now. But this may be another approach to treatment in the future, certainly for Parkinson's disease and maybe for Alzheimer's disease as well. So you have to stay tuned. The microbiome is complex. We're just really starting to figure out how to study it, and we'll see if this leads to new and different approaches to treatment.
Okay, so I'll make sure that I floss my teeth every night now, Dr. Chertkow. Okay, the next question I have here is, you mentioned hormones in your discussion about preventative factors. Is there any evidence that hormone therapy for postmenopausal women is helpful?
That's a very tough question because, scientists of the brain have looked at the brain of women premenopausal and postmenopausal, and the cells don't look the same. When women go through menopause, it's like if you think of a tree with lots of branches, that's a healthy brain cell, a healthy neuron. And then postmenopausal, half the branches have fallen off and it's much thinner and fewer connections. And that's a postmenopausal brain cell. Not surprisingly, women going through menopause and after menopause often complain of memory problems and concentration problems. The brain has been affected. So what does that mean? Well, estrogen is clearly good for the brain, and loss of estrogen during menopause has an effect on your brain. But can you then treat the brain issues by giving women estrogen supplementation? There was a big study where they decided to start estrogen in women at age 65 in the hope that this would prevent Alzheimer's disease. It did not. But maybe, and this made a big impact, because before then we were saying, yes, taking estrogen as during menopause will prevent Alzheimer's. Well, if you wait 20 years and start it, it's not having a benefit. How about if you take it from the time of menopause in the 40s? Well, the jury is still out on that. And it's hard for me to say one way or another whether estrogen taken at the time of menopause and continued is going to have an impact on Alzheimer's disease. The problem is estrogen is so complex, and any gynecologist will raise ideas about cancer and other negative effects of estrogen. So we can't at this point say every woman should go on estrogen to prevent Alzheimer's. We simply don't have evidence that that is true.
Thank you, doctor. I'm looking at, there are some more questions in here. it says here, do you have any concern about 5G EMF waves in people's homes from wireless internet network connectivity? So does that affect the brain? What is your opinion on that, Dr. Chertkow?
Well, my wife tells me that even now the recommendations from Apple and Google and so on are that you keep your cell phone 3 feet away from you while you're sleeping, and you go on airplane mode during sleep so you don't get as much electronics. Um, on the other hand, in terms of solid evidence that cell phones cause anything in the brain, we simply don't have that. And that includes, a lot of work on brain cancer. People hold their cell phone up to one side of their head. There really hasn't been evidence that they get more cancer on that side of the brain than the other. So we don't have any real evidence at this point that there's been any impact on Alzheimer's or dementia from microwaves or cell phones or electronic waves in the atmosphere. That evidence, to the best of my knowledge, doesn't exist. And certainly the Lancet Commission looked at this, and in their recommendations, they looked at what we know about risk factors, and cell phones and 5G and internet did not come down as a risk factor for Alzheimer's disease. Um, I think that I'm going to reinforce what I said. It's the most disturbing thing in the environment to think of now is pollution, and the evidence that there's growing evidence that if you live right next to a highway, that is having some impact on your brain. We have seen reports out of Mexico City, which is highly polluted city, where individuals in their 20s and 30s are getting some of the changes of Alzheimer's disease in their brain in their 20s and 30s. So I think this is going to be an area that we see getting more and more evidence. Yeah, and the latest is that in England, if you live in an area that has a lot of trees, a lot of parks, people have a lower rate of getting Alzheimer's disease. So the environment is very important. Pollution is playing a role. And I'm more concerned about that than I am about cell phones at this point.
So it would be your recommendation to actually have a live plant at home, right? Especially in the winter
Well,
time.
I think so. And green space and parks is not just for aesthetics. I think it is good for your overall health and good for your brain.
For my own personal experience, Dr. Chertkow, working with families, recently there's a lot more, especially for my young onset clients, a lot of my families have been really facing challenges in terms of managing agitation and anxiety. So some of them actually are prescribed with antipsychotic drugs and anti-anxiety drugs, but it seemed to not work. Are there any other recommendation that you would recommend families to manage this, as we call it, reactive behaviors?
Well, let me say this: there are a wide set of medications available to manage agitation and aggression and anxiety. And there's a wide range of lifestyle things that people can try and do to reduce anxiety and agitation in an individual with dementia. So it's not like the disease modifying therapy field where we've had nothing. We have medications. Now, certainly the specialists and the geriatric psychiatrists teach their students how to use them. Their algorithms about try this, and if this doesn't work, try this, and you can go down the road to 8 or 9 drugs. I think sometimes what is lacking is having a physician engaged who's willing to do that. So if there's a problem with agitation and aggression and anxiety, and a family doctor doesn't seem to be able to manage it, that is a sign that a specialist needs to be brought in, because we certainly have the tools, and why we have to sometimes see the patients a lot and try this and then try that. It's more an art than a science, but there are scientific algorithms about how to do it. You need to find a doctor who's going to give the time and has the expertise to really get involved in a situation like that.
Thank you, doctor. Another question is about the scans, because you said like PET scans are really effective in really diagnosing the patient. Unfortunately, it's as you said, it costs like thousands of dollars. For our families here in Quebec that are going through, some of them actually for years they've been seeing a neurologist and they haven't given any diagnosis still. What is your recommendation? How should this family, approach their neurologist? Because there's no diagnosis that is happening.
Yeah, I think actually Quebec is quite fortunate in having a lot of PET scanners. The government, for reasons that are for one reason or another, installed a good number of PET scanners, much more than in Ontario. And the patient doesn't pay for the PET scan. The price is absorbed in the hospitals that carry it out. So there is, I certainly, for patients who are where the diagnosis was unclear, now we have, if you're in an academic memory center at McGill or University of Montreal or Laval or University of Ottawa, they have memory clinics, they have neurologists and geriatricians who focus on memory, and they have access to PET, they have access to MRI, lumbar punctures and spinal fluid. And now we have a national center where you can send the spinal fluid to get amyloid and tau measures done. So all of these biomarkers are available, certainly to memory clinic specialists across the country. Now, if a neurologist is not giving a clear diagnosis, I think that's a reason to go back and have a discussion with the doctor and maybe phrase it in terms of, what is the diagnosis in, my father's illness? And if it's not clear, what else needs to be done to clarify the diagnosis? And sometimes and I think less and less, but sometimes the answer will be, well, it's not really going to make a difference in the management if we're clear on the diagnosis. All we have is this donepezil or galantamine or rivastigmine. I'm giving that already. So, what difference does it make if it's mixed dementia or Alzheimer's disease or vascular dementia? And so it's almost a little bit of diagnostic nihilism that the investigations aren't done because the treating doctor thinks it's not really going to make much difference. So I think now that we're getting more treatments, it's going to also push physicians to be much more specific in their diagnosis and use the biomarkers, because now there are anti-amyloid medications, but they only work if there's amyloid. So I think that the biomarkers are available, and diagnostic precision can be really pretty good at this point.
Okay, good to know, doctor, that at least for us, knowing this, we can really direct our families to advocate for themselves, to ask for this different biomarkers, the testing that is available for our families. Thank you. There is a question here regarding ultrasound to the brain. What do you think about it, Dr. Chertkow?
So, yeah. So there's a technique that's been developed, an experimental technique called focused ultrasound. And this is the Sunnybrook Hospital in Toronto is sort of a world center for this. And they take an ultrasound, they put someone in an MRI, station a helmet, and focus the ultrasound on a little area of the brain. And basically, it sort of heats up the blood and causes sort of big bubbles, and the bubbles push open the blood-brain barrier, so you can get a temporary disruption of the blood-brain barrier, and that would allow treatments that you give intravenously to get into the brain. I think this could be a breakthrough for treating brain cancer, because it would allow chemotherapy to get into a very specific area, get to the tumor and treat the tumor. I think this could be, they're still working on it. It could be a breakthrough. I can't really imagine why it would help Alzheimer's disease. Nevertheless, the Weston Foundation invested a good deal of money in promoting the research on focused ultrasound as a treatment for Alzheimer's disease. But at this point, there hasn't been results which, to me, reading the literature, tell me this is going to be a breakthrough for Alzheimer's disease. I think it may be a breakthrough for brain cancer. But it's possible that disrupting the blood-brain barrier could make Alzheimer's disease worse. So research has to be done. I think it's reasonable to do the research and try and publish it, but it's nowhere near being an actual proven treatment to be made available.
Okay. I have a question here from someone who has been recently diagnosed by MCI in his late 60s. Other than lifestyle changes, what medical treatment would you suggest to a layman at this early stage of MCI?
So, MCI is a label that covers a bunch of things, and it's not a diagnosis. It's the start of a diagnosis, and MCI just means there's some mild memory loss. The question is why, and you have to see a doctor, and they have to take a history, and they have to do a physical exam, and they have to order appropriate tests and try and get to an answer. I mean, 10% of MCI are related to sleep disorders, people with sleep apnea, and that can be treated. 15% are related to medications, and you might not realize you're on a medication that can impact on your memory. Another group are related to poor renal function, kidney function, thyroid function. Those have to be diagnosed and treated. So MCI is the diagnosis of MCI is not really a diagnosis. It means the doctor has to carry out tests to figure out why you have MCI.
Okay. I have here, Dr. Chertkow, are there any new findings for people diagnosed with behavioral FTD? She said, I know you have some research using electrode stimulation on the brain. Will it work for someone who has behavioral FTD?
Right. So FTD is frontotemporal dementia, and there be overlap in the symptoms with Alzheimer's, but tends to be a fairly distinct illness. It has an earlier onset. People get it in their 50s and 60s. It presents not so much with memory loss, but with change in behavior or change in language. And inside the brain, it's different chemistry. It's not amyloid. It can be tau protein or different proteins causing it. Very strongly genetic. In about half the cases, it's inherited from a parent. And it's a very difficult illness for which we have much fewer things to offer in terms of medication. There have been some studies to look at patients with behavioral variant FTD, where the problem is mainly behavior, to try and treat them with drugs against tau. Up till now, those haven't been successful, but there are new drugs against tau which are going to be coming this decade, and we are trying these right now for Alzheimer's disease. If they're successful, the next step will be targeting behavioral variant FTD. So I'm hopeful that maybe at long last we might have a real treatment approach. It's going to have to be tested experimentally, but these, I think, there are going to be things to offer in the next few years. What we are doing in my lab and a couple of others is using electrical stimulation. This is called direct current stimulation. It's almost like you put on a sponge over the head and attach it to a battery for an hour, and this stimulates brain cells while someone's doing memory or language exercises and seems to improve their function for a few weeks at least. We don't have evidence this slows the disease, but we're hopeful we're going to be able to show the next couple of years that it can improve the symptoms of certain patients enough that families notice an improvement. So sadly, for behavioral variant FTD, outside of this electrical stimulation, right now today, I know of no other drug studies or clinical trials or experimental research targeting these patients.
Thank you, doctor. I'm going through, did I miss anything? So despite, one last question, doctor, despite genetic testing for the general public not being recommended, would it be advisable for family members of a person with early onset dementia to get tested before being symptomatic?
So that's a very good question. So this is a situation where the patient and the family should have a long discussion with the doctor. Look, if nobody in the family has had Alzheimer's disease, obviously unlikely there's a gene, but we see families where one person has Alzheimer's disease and their brother has it and their father and multiple family members, suggesting there's some genetic element. It's perfectly appropriate for the patient, the person with the disease, to be referred to a geneticist and have genetic testing done. And the geneticist will decide which are the likely genes to check, depending on clinical features. And if the genetic testing is done and an abnormal gene is found, then the geneticist will say to the rest of the family, look, we have found this gene in your father. He has Alzheimer's disease. We think that the gene played a role, and we can make the genetic testing available to family members or children who don't have any symptoms. So the first step is finding the abnormal gene in the person with the disease, and then the geneticist will discuss genetic testing with other family members. And there are neurogeneticists in Montreal, and referrals can be made to the genetics department. It is, if you're in a family where there is any disease, which is in multiple family members, the thing to do is to get to a geneticist now, because the worst thing is, what happens if the person with Alzheimer's disease dies next year and no one ever found out from their blood from doing the test, did they have a gene or not? So then, you want to collect the blood and do the testing now, before the person gets too severe.
That's all the questions that I have right here, Dr. Chertkow. Thank you very much for your time. We really appreciate your expertise and the knowledge that you have imparted to us tonight. May this be not the last time. We are hoping to have you again in the future, especially with all the research that you are interesting research that you're doing right now at present. For sure, it will shed light to all the questions that we have and for all the concerns that we have for our families and for the families that are living with dementia. So
Very
again,
happy
we
to
are,
be here.
oh, sorry. Go. Thank you,
Happy to
Brad.
be here tonight, and good luck to all of you, and carry on the good work you're doing in the Alzheimer's group. You're doing wonderful work.
Thank you, Dr. Chertkow. Again, we are the Alzheimer's group. Ladies and gentlemen, we are not, we are a charitable organization. So if you are or someone you love is diagnosed with dementia or any forms of dementia, please feel free to contact us at 514-485-7233 or email us at info@agiteam.org, and we will be happy to get back to you. So we offer counseling for families, education, support groups, and for people living with dementia, we also have our activity center. We have the art therapy, our music therapy, and our support groups as well for people living with dementia. So on this note, again, thank you very much for your time. Again, Dr. Chertkow, thank you very much. And good health to everyone. Make sure to floss tonight. Okay, thank you very much and have a good day, everyone. Bye.
Very welcome. Bye for now.